This presentation will be followed by a Q&A session where attendees will have the opportunity to ask questions. You can either submit written questions via the Q&A box, or you can raise your hand to ask a question via the webinar audio. CMS subject matter experts will address as many questions as time allows. A recording of this webinar and accompanying slides will be shared online to the Quality Payment Program webinar library in 2 weeks. Now I will turn it over to Jeanette Ellis at CMS to begin. Jeanette?
Yes. Thank you, Hallie. Good afternoon. On behalf of CMS and our support teams, thank you for joining our MVP Development and Maintenance Annual Webinar. Again, my name is Jeanette Ellis. I am currently serving as the MVP Development and Maintenance Lead here at CMS. Next slide. Over the next several slides, I, along with Deborah Kaldenberg, will be providing an overview of our MVP program, as well as highlighting 2024 MVP policy updates, MVP candidate submission and review processes, and the MVP maintenance process. We will wrap up by providing links and information on how you can seek help and support on the subject, followed by our Q&A session. Next slide. And next slide. So you may ask yourself, why MVPs? From the time the Quality Payment Program launched in 2017 to today, CMS has strived to take steps in updating the MIPS and APM's participation tracks. Our approach has factored and acknowledged the unique clinician practices, program requirements, feedback from you and the public, and reporting burden. We believe these aspects have led to more meaningful participation, thereby improving patient outcomes. Our MVPs are a subset of measures and activities that can be used to meet MIPS reporting requirements. In addition to achieving better health outcomes and lowering costs for patients, we anticipate MVPs will result in comparable performance data that helps patients make more informed healthcare decisions. Next slide. We recognize this is a significant shift in the way clinicians may potentially participate in MIPS, and we are committed to a smooth transition to MVPs that doesn't immediately eliminate the traditional MIPS framework. Clinicians still have the option to participate through traditional MIPS, and we haven't finalized a timeline for when traditional MIPS will no longer be available. Next slide. And next slide. I'll now provide some highlights regarding our MVP policy updates. As explained in our calendar year 2023 PFS final rule, we brought in opportunities for the public to provide feedback on the MVP candidates. Once an MVP candidate is deemed feasible, CMS posts the MVP candidates on our QPP website to solicit feedback for a 45-day feedback period. This feedback will be posted on our QPP website. Please note, the posting of the MVP candidate's feedback doesn't guarantee the candidate will move forward in rulemaking. We will not respond to individual feedback. Also of note, CMS will review the feedback and determine if any recommended changes should be incorporated into a candidate MVP. If CMS does determine changes should be made, CMS is not required to notify the group or organization that originally submitted the MVP candidate in advance of rulemaking. Next slide. Further elaborating on MVP policy updates, the MVP maintenance process allows general public to recommend changes to previously finalized MVPs on a rolling basis. CMS will host a public webinar to give general public an opportunity to provide feedback on potential revisions previously finalized in the MVPs. Next slide. MVPs will be available gradually, beginning with the 2023 performance year. Our intent is to provide practices, healthcare organizations, and third-party intermediaries the time they need to review requirements, update workflows, and prepare their systems as needed to report MVPs. Of note, for the 2023 2024, and 2025 performance years will allow individual clinicians, single specialty groups, multi-specialty groups, subgroups, and APM entities to report MVPs. For the 2026 performance year and for future years, will allow individual clinicians, single specialty groups, subgroups, and APM entities to report MVPs. Next slide. Please note that the following regarding our MVP registration reminders. MVP participants must register between April 1st and November 30th within the applicable performance year or a later date specified by CMS in order to report an MVP. Registration participants must select the following in order to register: the MVP that they intend to report on, one population health measure included in the MVP, and any outcome-based administrative claims measure on which the MVP participant intends to be scored if applicable or available. MVP participants will not be able to submit or make changes to the MVP they selected after the close of the registration period, which is November 30th of the performance year, nor will they be able to report on an MVP they didn't register for. Next slide. In terms of MVP registration for subgroups, subgroup reporting will be voluntary for the 2023, 2024, and 2025 performance years. Multi-specialty groups that report through an MVP will have to report as subgroups beginning with the 2026 MIPS performance year. In addition, the subgroup registration must include a list of taxpayer identification number, or TIN, as well as national provider identifiers, the NPIs, in the subgroup. It must also include plain language name for the subgroup, which will be used for public reporting, and a description of the composition of the subgroup, which may be selected from a list or described in narrative. The clinician will therefore only be allowed to register for one subgroup per TIN. Next slide. Continuation for the MVP registration as it applies to subgroups. CMS will use the initial 12-month segment of the 24-month MIPS determination period to determine eligibility of clinicians intending to participate or register as a subgroup. Subgroups inherit the eligibility and special status determinations of the affiliated group, which is identified by the TIN. The TIN will need to participate as a subgroup, the TIN will need to exceed the low volume threshold as the group level. Subgroups will not be evaluated for the low volume threshold at the subgroup level. Also of note, the subgroup will inherit any special statuses held by the group, even if the subgroup composition does not meet the criteria. Subgroups will not be evaluated for special statuses at the subgroup level. Next slide. For third-party intermediaries, we recognize that many third-party intermediaries may not support measures for clinicians in all specialty areas that might report an MVP. As a result, CMS is clarifying that all qualified clinical data registry, QCDR, or a qualified registry must support all measures and improvement activities available in the MVP with two exceptions as noted here. If an MVP includes several specialties, the QCDR or qualified registry is only expected to support the measures that are pertinent to the specialty of their clinician. Also, QCDR measures are only required to be reported by the QCDR measure owner in instances where a QCDR doesn't show the QCDR measures in the MVP. The QCDR can only support the QCDR measures if they have the appropriate permissions. Next slide. For the next couple of slides, I will be highlighting our MVPs. On this particular slide here, you will see our previously finalized MVPs, which includes emergency care, cancer care, heart disease, rheumatology, stroke care prevention, surgical joint repair, nephrology, neurology, anesthesia, primary care, and neurology. Of note, all of our previously finalized MVPs have been finalized with modifications. Next slide. Our newly finalized 2024 MVPs include women's health, otolaryngology, infectious disorders, mental health and substance use disorders, and musculoskeletal care. Next slide. The reporting requirements for MVPs is comprised of the participant requirements and foundational layer. The participant requirements are broken down into quality, improvement activities, and cost. For quality, participants must select 4 quality measures, one of which must be an outcome measure or high priority measure if an outcome measure is not available. For improvement activities, participants must select either 2 medium-weighted, 1 high-weighted improvement activity, or the IA PCMH if available in the MVP. For cost, MVP participants will be scored on the cost measures included in the MVP. These are calculated automatically using administrative claims data, so clinicians do not need to choose which cost measure to report. However, of note, if a cost performance category score cannot be calculated for a clinician or group, the cost performance category is reweighted following the traditional MIPS scoring policies. Leading into the foundational layer, this includes our population health measures as well as promoting interoperability. For population health measures, MVP participants will select one of the population health measure. CMS will then calculate the population health measures for you using administrative claims data, which the results will be added to the quality score. For promoting interoperability, again, participants will report on the same promoting interoperability measures required under traditional MIPS, unless they qualify for reweighting of the promoting interoperability performance category due to the clinician type, special status, or an approved promoting interoperability hardship exception application. Subgroups will submit promoting interoperability data at the group level, not the subgroup level. Next slide. In terms of measure and activity scoring for MVPs, the quality category measures are scored in alignment with traditional MIPS. This includes measures receiving between 1 and 10 measure achievement points, meeting the minimum case requirements, and data completeness thresholds, scoring flexibilities for measures with changes during the performance year, and a no 3-point floor with the exception of small practices. We will use the 4 highest scoring measures if an MVP participant reports more than the required number of quality measures. For cost, measures, again, are scored in alignment with the traditional MIPS. Only cost measures included in the MVP selected by the MVP participant will be scored, and subgroups will be assigned the affiliated group score, if applicable. For improvement activities, the medium-weighted improvement activities will be assigned 20 points. High-weighted improvement activities will be assigned 40 points. This differs from traditional MIPS, where medium-weighted improvement activities are assigned 10 points and high-weighted improvement activities are assigned 20 points. Next slide. For the foundational layer scoring aspects, the population health measures selected by MVP participants will be included in the quality performance category score. These measures will be excluded from scoring if the measure doesn't have a benchmark or meet case minimum, which is similar to our administrative claims measure policies in traditional MIPS. Note, for population health, measures are not considered a separate or new performance category, and the exception for subgroups will receive the score of the population health measure of their affiliated group, if applicable, if the measure selected by the subgroup doesn't have a benchmark or meet the case minimum. The promoting interoperability measures are scored in alignment with the traditional MIPS scoring policies. Subgroups will submit promoting interoperability performance category data of their affiliated group. Next slide. Yep. Oh, there we go. Determining the final score for MVPs will generally be aligned with traditional MIPS performance category weights. The reweight policies for MVPs also align with traditional MIPS. However, there is an exception. The quality performance category will not be reweighted if CMS cannot calculate a score for the MIPS eligible clinicians because there isn't at least one quality measure applicable and available to the clinician. MIPS eligible clinicians will receive the highest final score attributed to their 10 MPI combination from any reporting option, such as traditional MIPS, APM, or MVP, and participation options, such as individual, group, subgroup, or APM entity. Note, CMS will not assign a final score to a subgroup that registers, and CMS does not submit data as a subgroup. Next slide. For the MVP development process, there are 6 stages or phases, which are highlighted here. The MVP candidate development, in which CMS or an interested party develops the MVP candidates based on the MVP needs and priorities. Candidates are developed on a rolling basis with key guiding principles. This leads into our MVP candidate review, at which point CMS reviews and discusses the candidate with the interested party or parties that submitted the MVP candidate. CMS will then determine whether MVP candidates can move forward in the development process. During the MVP feedback period, the candidates are available on the QPP website for feedback for a 45-day period. CMS will display the feedback received related to each MVP candidate at the end of the 45-day window. However, of note, posting of MVP candidate for feedback does not guarantee the candidate will move forward in rulemaking. At the proposed MVP stage, CMS determines whether to incorporate an MVP. It will be proposed through rulemaking. For the candidates that are proposed in the finalization stage, they may be finalized through rulemaking with or without modification based on the feedback received. You are able to view the finalized MVPs on our Explore MVPs website. And then the final stage for the MVP maintenance, this is the process where the general public can provide feedback on finalized MVPs for CMS consideration. Next slide. I will now hand it over to my colleague, Deborah Kaldenberg, to discuss the MVP candidate submission and review processes as well as MVP maintenance.
Thank you, Jeanette, and good afternoon. My name is Deborah Kaldenberg, and I will continue covering the next 3 sections of this presentation. This first section covers MVP candidate submission. Next slide, please. CMS invites the general public to submit MVP candidates for CMS consideration and potential implementation through future rulemaking. MVP concepts can be submitted on a rolling basis through the call for MVP process. In order to submit an MVP candidate for CMS consideration, the MVP development standardized template would need to be completed and emailed to PIMS MVP support at gdit.com for evaluation. The template can be located on the QPP website in the MIPS Value Pathway section. Please note this process is separate from the annual call for quality measures, call for improvement activities, call for cost measures, QCDR self-nomination, and solicitation for specialty set recommendations. Next slide. The MVP needs and priorities described below and in subsequent slides support CMS's goal to continue MVP development by providing guidance on the clinical topics identified as current gaps in MVP development. By addressing these gaps, we will be able to continue development of MVP options for clinicians. We encourage the general public to review this document and consider the following. 1, when submitting MVP candidates that cover the bulleted specialties and clinical topics, and 2, assist in addressing identified gaps in improvement activities and quality and cost measures availability for these topics. Next slide, please. The next four slides will cover general and performance category-specific MVP candidate submission guidance. Starting with general guidance, MVP candidates must follow the MVP guiding principles. The MVP guiding principles consist of limited, connected, complementary sets of measures and activities that are meaningful to clinicians, include measures and activities resulting in comparative performance data that is valuable to patients and caregivers in evaluating clinician performance and making choices about their care, promote subgroup reporting that comprehensively reflects the services provided by multi-specialty groups, include measures selected using the meaningful measures approach, and whenever possible, include the patient voice, reduce barriers to alternative payment model participation by including measures that are part of APMs and by linking cost and quality measurement, and support the transition to digital quality measures. For additional guidance, you can view the MVP candidate development and submission on the website, on the QPP website. Next slide, please. Moving on to quality performance category guidance, consider whether the quality measures are applicable to the MVP topic and the clinicians and/or groups providing care. Note the available collection types of a given quality measure. If possible, include QCDR measures that meet all requirements for inclusion. Of note, the current inventory of MIPS quality measures and QCDR measures include both cross-cutting and specialty clinical topic-specific quality measures. The current MIPS quality measures list and their associated specialty set and measure properties are available in the 2024 MIPS quality measures list and 2024 cross-cutting quality measures on the QPP resource library. The current QCDR measures list and measure properties are available in the 2024 QCDR measure specification, again on the QPP resource library. Next slide, please. The improvement activities performance category guidance includes the following. Prioritize activities that best drive the quality of performance addressed in the MVP topic. Improvement activities should complement and/or supplement the quality action of the measures in the MVP candidate submission rather than duplicate it. And the inclusion of health equity-focused improvement activities is encouraged. Please review the 2024 Improvement Activities Inventory on the QPP Resource Library for additional information. Next slide, please. And finally, the cost measure performance category guidance. MVPs must include a cost measure to be considered as a viable MVP candidate. The current inventory of cost measures includes population-based cost measures and episode-based cost measures. Procedural episode-based cost measures apply to clinicians, such as orthopedic surgeons, that perform procedures of a defined purpose or type. Acute episode-based cost measures cover clinicians, such as hospitalists, who provide care for specific acute conditions requiring a hospital stay. Setting episode-based cost measures apply to clinicians who provide care to patients in specific settings, for example, the emergency department. Chronic condition episode-based cost measures account for the ongoing management of a disease or condition. Population-based cost measures assess episodes of care built around a patient's admission to an inpatient hospital. And overall costs of care reflecting an ongoing primary care type relationship. And in these cases, those are the MSPB or Medicare spending per beneficiary clinician measure and the TPCC or total per capita cost measure. Next slide, please. And now we're going to cover the MVP candidate submission and review process. Next slide, please. In order to have an MVP candidate considered by CMS for potential implementation beginning with the 2026 performance year and future years, the MVP development standardized template should be completed. This template is available on the QPP resource library. The MVP candidate must include measures and activities across the quality, cost, and improvement activities performance categories. Each MVP includes what is referred to as the foundational layer. This foundational layer includes the entire set of promoting interoperability performance category measures, as well as 2 population health measures. The 2 population health measures are Quality Measure 479 and Quality Measure 484. Next slide, please. Table 1 and Table 2A of the template must be completed in order for CMS to consider the submission. Table 1 includes high-level descriptive information such as the MVP name, point or points of contact, intent of measurement, measure and activity linkages within the MVP, appropriateness, comprehensibility, and incorporation of the patient voice. Table 2A includes the specific quality measures, improvement activities, and cost measures for the MVP candidate submission. Tables 2B and 2C are pre-filled with the foundational layer measures for each MVP candidate submission. Next slide, please. Submitting a candidate doesn't guarantee a meeting with CMS or acceptance of the MVP for the rulemaking process. CMS will conduct an internal review of the MVP candidate and reach out to the MVP submitter with questions if necessary. If CMS determines a meeting is needed, they will engage in an iterative dialogue with the MVP submitter. CMS may require the submitter to collaborate with similar groups to help ensure MVP candidates meet clinician and patient needs. Next slide, please. A component of the MVP process is an opportunity for the general public to review and provide feedback on potential MVP candidates prior to rulemaking. For the general public, 2025 MVP candidates will be available for review on the QPP website for a 45-day period, beginning on December 15th. The general public is invited to review the MVP candidates and submit feedback and recommendations to the PIMS MVP support at gdit.com mailbox for CMS's consideration. Please note this process doesn't apply to previously finalized MVPs. CMS will display the feedback received on the MVP candidates on the QPP website following the 45-day candidate feedback period. CMS will also review feedback and determine whether to incorporate recommendations into an MVP candidate before potentially proposing in rulemaking. Please note it is possible not all MVP candidates will be proposed in rulemaking. CMS won't post feedback that is considered unrelated to the MVP candidates and won't directly respond to any feedback received. And finally, CMS won't consult with the group or organization that submitted the MVP candidate or with the interested party that submitted feedback on an MVP candidate in advance of proposing new MVPs through the rulemaking process. Next slide, please. There are 6 potential 2025 MVP candidates that will be posted for general public feedback on December 15th, beginning the 45-day period. Those MVP concepts include comprehensive ocular care, dermatological care, gastroenterology care, pulmonology care, surgical care, and optimal care for patients with urologic conditions. Next slide, please. After the 45-day candidate feedback period, CMS will identify proposed MVP candidates through the physician fee schedule, notice of proposed rulemaking. CMS will indicate finalized MVPs exclusively through the Medicare PFS final rule. The submission of and/or the posting of an MVP candidate for general public feedback doesn't mean it will be selected or implemented in future years. While the goal is for the MVP candidate submission and review process to be a collaborative process with CMS, CMS as the governing agency will make final determinations about MVPs. Next slide, please. And the final topic that I'll be covering is the MVP maintenance process. Next slide, please. The general public can submit recommendations on a rolling basis for proposed revisions to established MVPs. Established MVPs are those that have been finalized through the rulemaking process, and as shared earlier in the presentation, there are currently 16 established MVPs. Recommended changes should be submitted by email, again to the PIMS MVP support at gdit.com mailbox, and be broken down by performance category. We ask that you include the title of the MVP along with a description of the recommended changes broken down by performance category. Please refer to the table format in the MVP maintenance process PDF when submitting your recommendations. Next slide, please. So what happens after you submit your feedback? Your recommendations submitted through the PIMS MVP support at gdit.com mailbox prior to the February maintenance webinar that are deemed feasible will be included in the webinar for the public to have an opportunity to provide feedback. Any potential changes to MVPs will be addressed through future rulemaking. And finally, CMS won't communicate with the general public about whether recommendations were accepted outside of rulemaking and will ultimately decide whether updates to established MVPs should be made. Next slide, please. Recommending changes to existing MIPS measures and improvement activities with an MVP. Any of these modifications to existing MIPS measures and improvement activities in traditional MIPS, including removal from the inventory, will be reflected in any MVPs that include those measures and activities. For requests to change existing individual MIPS measures and activities, please note the following. Changes to MIPS quality measures may be submitted for consideration during the proposed rulemaking comment cycle or by contacting the measure steward directly. Changes to existing improvement activities and cost measures may be submitted for consideration through the annual call for measures and activities. This brings to a close the overview of the MVP candidate review and maintenance processes, and I'll be handing it back to Jeanette Ellis. Thank you for your time. Next slide, please.
Thank you, Deb. So leading into our help and support, go to the next slide, please. For new MVP resources, we have more information available regarding MVPs on the following web pages, as well as downloadable new and helpful QPP resources. This includes our MVP Learning Experience webpage, the 2024 QPP Final Rule MVP Guide, Transition from Traditional MIPS to MVPs graphic, and our MVPs Overview video. Next slide. Additional MVP resources that we encourage you to review include past webinars for more information, as well as, again, the reviewing of our 2024 QPP Final Rule. And as I noted, the previous MVP's webinar slide deck and recording, which is available on our QPP webinar library. And then you can also find additional information available on our QPP website at the link provided below. Next slide. And here I'll hand it back over to our support team for our question and answer session.
Thanks, Jeanette. So we're now going to start the Q&A portion of the webinar. As a reminder, you can ask questions using the Q&A box, or you can raise your hand to ask a question via the webinar audio, and we will unmute your line. Okay, it looks like we have a question from Bridget. Bridget, we are unmuting your line. You'll have to unmute yourself also to answer the question.
Hi, good afternoon. I'm trying to get some clarification on how CMS is determining if a practice is considered multi-specialty. I'd asked a question in the Q&A, and it looks like Sophia Shigumar replied that a practice is considered multi-specialty if they are made up of more than one specialty type. So my question is, where is CMS looking to determine a specialty type? Is this based on PACOS? Is this based on procedural billing, CPTs that are submitted? I'm trying to understand where we can find this information and determine if CMS would consider us a multi-specialty type or not.
Thanks, Bridget. Hi, it's Sophia. As a follow-up to my response, the data sources that we would use, I believe, are primary Part B claims, the claims data, and secondary to that would be PACOS.
Okay, do you have any sort of documentation that indicates which claims would be, or which CPT codes would be indicative of one specialty as opposed to another?
I don't know that we've come up with more granular documentation on that. That is probably something I'd have to follow up with the team on to see if there's any additional information. If you'd like, if you could submit like a service center ticket, we're happy to follow up on that one.
Great, thank you.
Thanks.
Thank you, Bridget. And thank you, Sophia. Okay, so we have some questions in the question and answer box. The first question that we have is, we are a multi-specialty group that is part of an ACO. If we register for the Neurosupportive Care MVP, are we required to register for other MVPs? And would we have to suspend traditional MIPS?
Hey, good afternoon, Renee. So I'm going to answer this question, and then I'm sure you may have others that may weigh in that are on here as support. But I want to kind of piece this out a little, break it down a little bit. So first of all, you can register for the Neurosupportive Care MVP. You don't have to be exclusive in reporting on just one single MVP. So are you required to register for MVPs? We don't require that because the registering for MVPs is not a mandate. And then to answer that last question, will we have to suspend traditional MIPS? And the answer to that is no. And so I'll lean on others who want to add additional context, or certainly if you want to come offline and answer your question live, but hopefully that answers your question. You're not required to register for other MVPs, and you don't have to suspend your traditional MIPS.
Yeah, and I would just clarify that for 2023 for reporting, MVP registration is now closed. So registration is not open for additional amendments, but you could thinking forward for 2024, if you haven't registered already, you could possibly register for an MVP and report that MVP. And in addition to that, continue to report your traditional MIPS submission. Well, what would happen on the scoring side is we would not aggregate those two submissions into one. We would calculate your MVP submission and come up with the final score, and then look at your traditional MIPS submission separately and calculate that as well. And we'll compare the two, and whatever is the highest would become your ultimate final score. So there's nothing that would preclude you from registering for an MVP and not reporting the MVP, or registering and reporting then the MVP, and also in addition to that, reporting traditional MIPS as well, you're still allowed to do that. There's still those flexibilities in place. But just clarifying for 2023, MVP registration is closed.
Thank you, Sophia, and thank you, Jeanette. It looks like we have a question from Renee. Renee, if you would please unmute your line.
Right, thank you. So we are also part of an ACO. So if we were to submit only the neuro MVP, and then as well as our traditional MIPS and the ACO piece, would it be the higher of the three in 2024?
Yeah, that's participating in MIPS?
Yes.
Yes. Okay, yes, then the scoring hierarchy is in place.
Okay, so we could essentially do all three and not have to do, and we could just do only the one neuro MVP and no other MVPs.
Are you reporting the MVP as a subgroup or a group?
It'd be a subgroup.
Okay. So the subgroup, the neurology MVP score would only apply to those in the subgroup, not your whole ACO, not your whole 10, just to be clear. Okay. So you would have available to you your MVP score at the subgroup level versus your group level score in traditional MIPS versus like your ACO score, and then we take the higher F. So if your group score is higher, then we would apply that to the subgroup. But if your subgroup, for whatever reason, scores higher than the group, then the subgroup gets their own score, but we cannot apply that to the rest of the group.
Okay. Thank you. I just wanted to make sure that we could. And then just to clarify too, we're okay to only submit one MVP. We wouldn't have to do like a couple other MVPs. Can you do just one?
As a subgroup, you can only register for one MVP.
Okay.
And if your ACO, your 10 can certainly form multiple subgroups, but that's to your discretion as to what makes the most sense versus compared to what's available from an MVP reporting perspective. So if only one MVP is available, that makes the most sense for a caveat or a carve out of some of your neurologists, then we would assume that everyone else would continue to report traditional MIPS while this cohort is reporting on the MVP.
Okay. All right. Thank you.
Mm-hmm.
Thank you, Renee. All right, just as a reminder, you are welcome to raise your hand to ask questions via the phone, or you can utilize the Q&A box. But moving on, we have another question from the Q&A. Can we utilize JSON to submit quality for MVPs?
Yeah. Sorry, go ahead. Sorry, I didn't know if someone was speaking. So Teresa, thank you for that question. Actually is going to lean into our product support team on this particular question. If they're not on the call right now, I would encourage you to submit the question via our ServiceNow ticket. But if someone is on from product is on, please lean in and help answer Teresa's question.
So I believe our file formats that are available in traditional MIPS are continuously available within MVP reporting, but that is probably a question we would want our product team to confirm the response to. So we could definitely circle back on that one.
Okay, thank you. Moving on, we have a question from Kelly in the chat. As a multi-specialty clinic, we would like to try MVP for family medicine as a group as well as individuals. However, we have other specialties that would not fall into this measure. We are all 110. So can we have more than one subgroup such as speech-language pathology and PT/OT, or can we only use one subgroup at the individual level? some of the provider would not be eligible for individual reporting.
Okay. Thank you, Kelly, for the question. I'm going to kind of break this down a little bit, so hopefully I'm following you. So my understanding is that the 10 can be divided into multiple subgroups. However, a single subgroup can only register once. In saying that, there's nothing that says clinicians cannot be a part of multiple subgroups. So I don't know if that helps answer your question, or if there's others on the phone that would be able, or on the call that would be able to add additional context. But that is my understanding for how we handle multiple subgroups.
Yeah, and I just will add to that, because the question refers to group as well as individuals. So you have what seems to be a multi-specialty group, and you have a cohort of clinicians that are family medicine practitioners that are practicing as a group, but you also have individuals as well. You're asking whether how you have other specialties as well. So I will say for the first part with family medicine, if they want to report on the primary care MVPs, they are welcome to do so as a group, but also separately as individuals. If you're going to do that, you have to register as individuals to report as an individual for an MVP, just flagging that. And again, as I mentioned before, for 2023, registration has closed. It closed on November 30th. So looking forward to I'm thinking in the perspective of 2024 reporting. If you haven't registered already, you could register as a group, but also have individuals registered as individuals, as long as they're eligible at the individual level. So they have to be MIPS eligible. If they're not individual, they can't report in that way. Similarly, for your other cohorts of clinicians that are multi-specialty, in which you're asking whether you can break them down into, I think, a subgroup. For example, one that's speech language pathology specific and another that's PTOT. You would, in all likelihood, have two separate subgroups that would allow those clinicians, because your subgroup has to register on an individual basis. Your one subgroup can only register for one MVP, so they could not have one subgroup registered to two MVPs and then have your clinicians that are speech language pathologists only report on one MVP while your therapists report on another. So you'd have to be mindful of that registration, and I guess the way in which you want to break down into subgroups versus the availability of MVPs, and just keep in mind that each of your subgroups can only register for one. So I just keep that in mind. And then in considering individual reporting, just also keep in mind their eligibility status and their ability to register separately in order for them to report separately from their group.
Thank you, Sophia. It looks like we have a question from Juanita from the phone. So Juanita, I have unmuted your mic if you can unmute yourself.
Okay, can you hear me?
Yep.
Okay, great. Yeah, our group is a very large group, but 95% of it is family medicine, so we can do the one MVP. But for also in our group, we may have like one cardiologist, one neurologist, and so do we have to do a separate? Can we do a separate MVP for just one provider, or can those providers continue under MIPS? Because I think I calculated like we would have to do 18 different MVPs to get all of the providers in our group.
So right now, oh, go ahead.
No, you're okay, Sophia. Go ahead.
Hey, Juanita. So for the time being, MVP reporting is optional. So if you have a large number of family medicine clinicians that can report on one of the primary care MVPs, or one of the primary care MVPs, then you have some direction with them in terms of them forming a subgroup. For your other clinicians, it's really to your discretion. And I guess also considering their eligibility to report as an individual, really as to whether or not you would like them to report on the specialty available MVPs that are available to them, or whether they continue to report traditional MIPS at this point. I think is up to the group or the practice to decide that. Ideally, the more familiar the clinicians become and the specialists become with the MVPs, it makes the eventual transition easier, but certainly the timing of that is still to be determined, and we don't want to decide for you what's the best, but I would just say that probably thinking through that as a part of your long-term strategy would be advisable.
And kind of a second part of that, do we have to report, like, for example, women's health, we have nurse practitioners, and then we also have the MDs. Is it okay for the women's health MVP only? We wanted to only put our nurse practitioners in that group and not the MDs because their practice is significantly different. Is that allowed, or do they all have to go into the same MVP? If they're
you mean the same subgroup or same MVP?
The same subgroup.
Yes. So I'm sorry, that you're right. They don't have to be. The subgroup formation, whether you have two distinct subgroups because you want to carve out your practitioner types that way, that's up to you. We don't require it. For us, you could hypothetically have your nurse practitioners and your medical doctors in one subgroup. We would not say that's wrong. But if you feel that it's important to separate and create some distinguishment, that would be fine from our perspective.
Thank you.
Yep, no problem.
All right, thank you. And it looks like we have another question from the phone from Jill. So Jill, I've unmuted your mic. If you could also unmute yourself, please.
Yep, thanks. Can you hear me okay?
Yep.
Good. You've touched on eligibility a little at the individual level. My question is more at the subgroup level. If we have a TIN that we would like to subgroup providers that are not individually required to report but can voluntarily report, is that okay? Or does one of them have to be?
So typically for subgroups, hi Jill, the minimum requirement from an eligibility standpoint is at least one MIPS eligible clinician is a part of that subgroup. So you can have voluntary participants in there, but you need to have at least one MIPS eligible clinician in there in order for the subgroup to be approved as an official subgroup. So the subgroup member usually carries the eligibility status of their group. So if they're eligible at the group level, they need to continue to, as a subgroup member, if they're the only eligible member, they need to have that eligibility, be able to meet our low volume threshold or criteria in order to be deemed as MIPS eligible, so that the rest of the members of the subgroup don't necessarily have to meet those requirements. They can be opt-in eligible or voluntary participants.
Okay. But the one has to say, like, yes, individual, yes, group. That's
yeah.
Okay.
Yeah. So that's to the 3 LBT criteria. Yep.
Yes. Okay. And then can I sneak in a second question?
I think so, because it looks like we're running low on questions. So.
Okay. I'm looking at, so we primarily, or actually only report ECQMs at this point in time. And it's my understanding that if an MVP does not have an outcome measure that's an ECQM, but it does have a CQM outcome, we wouldn't be able to report it then if we're only using ECQMs, correct? We can't do a high priority ECQM because we don't use that type of reporting.
So the requirement generally for quality reporting is you must report one outcome measure, or if an outcome measure is not available to you, a high priority measure. So if there's in that situation, if there's an ECQM that's a high priority measure, then that satisfies that requirement. You wouldn't be dinged for not reporting the outcome. But If you can report an outcome measure, obviously that's the most desirable outcome. But if that would require you to use multiple collection types and that's not within your purview to do so, you don't have the technical capabilities as an example, then the expectation is still within the MVP, you're reporting 4 measures. If you can't report an outcome, 1 is a high priority measure.
Okay. So even if a CQM is available, it's because our reporting is not using CQMs, it can be high priority.
Right. So if it's available, but like available in a sense, it's within the MVP. What I mean by available is like you have the technical capabilities to report it. If you're doing solely electronic, sorry, I don't know why I said electric, electronic submission, and you're only reporting on eCQMs, the underlying assumption is you're looking for all 4 measures to be eCQMs within your MVP submission. So as long as one of those is high priority, when an outcome is not available, you're safe. You're fine in terms of meeting that requirement.
Okay. Thank you so much.
Thanks.
All right, thank you. So it looks like we've answered all of the questions in the queue. If anyone has any additional questions, please feel free to raise your hand or submit your questions through the Q&A box. All right, it looks like we have a question coming through on the phone. So Sandeep, I am unmuting your line if you would like to unmute yourself.
Hi, thank you for the opportunity. I actually did ask question in the chat group. I will just make it a little simpler. So does MVP support submission through multiple text IDs?
So the TINs are individually can report an MVP. We would not be doing aggregations of data across 3 separate tax IDs for a given submission. The option, I think I'm reading your question, the option to report as a virtual group is there, but I am not, I would have to check to see what the criteria is to meet virtual group requirements, and there's a registration process for that as well. Typically, when you submit an MVP, it's at the individual TIN level. So if there are 3 different TIN, then that would require 3 different submissions.
Oh, okay. All right. Thank you. Yeah, the only thing with virtual grouping was because this is small practice and they may not qualify the minimum threshold of 90K. But then again, I was reading some exception that with small practice, that's an exception, but I will follow up with the support team regarding this.
That would be great, because there are some small practice policies we have in place that might be provide some relief. So it'd be good to get additional detail from you.
Thank you.
Thanks.
All right, thank you. Did we have any other questions on the line? Okay, and it looks like we have just about run through our questions in the Q&A queue. So we will hold on a couple more minutes just to see if anyone else has any questions that they would like to submit. All right, well, seeing that there were no further questions in the chat or on the line, this will conclude our Q&A portion of the webinar. So we'll turn it back over to Jeanette Ellis to conclude the call. Jeanette?
Yes, thank you, Hallie. Again, on behalf of CMS and our support teams, thank you again for your participation today. We look forward to continuing our efforts in improving health outcomes and lowering costs for our patients. Have a wonderful day.